Hi guys, welcome to the part 2 of our high yield neuro review. In this part, we're going to be focusing on psychiatric disorders along with pharmacology. So let's get started, and you're going to see a bunch of memes, and they're going to usually lead us into what we're going to be talking about next. So this one, you can see we're going into neurodevelopmental disorders. So let's get started. So pause and try to answer these first yourself, and then once you're ready, you can unpause to hear the answers. Okay, so global developmental delay is usually in kids who are less than 5 years of age and they are unable to undergo testing, but it does look like they have an intellectual disability. Autism spectrum disorder, let's read this. It's an 8-year-old boy who has a hard time making friends, number one, keeps arranging his Lego pieces into a neat line, number two, and is able to identify most of the 2,000 bridges in New York, number three. So, what you can see here is they have social issues like communication, social relationship building is hard for them. They have this repetitive behavior of some sort, like arranging their Lego pieces in a neat line. And they usually have unique, like specific interests. For example, I actually have someone in my family who has autism, and that kid will, whoever he meets, he's gonna ask, "Oh, when's your birthday?" He's gonna ask about birthdays. He's obsessed with birthdays, and he's so good at it. Like he'll remember the birthday of someone he met like 5 years ago. So they're really good at these specific interests that they have. So those are, the classic three signs of autism. Moving on to ADHD. ADHD is diagnosed before 12, unlike many med school students who might think like, "Oh, I can't pay attention in school, let me go and get some Adderall." But that's not how it works. You have to have had inattentiveness and hyperactivity before the age of 12 and in at least two different settings, so school and home, for example. Okay, next is oppositional defiant disorder. You can see here these kids have like outbursts, and they also have defiant behavior. So they will argument with you. They'll show aggression, vindictiveness, and this will has to last at least more than 6 months for you to make the diagnosis. Usually, I think 6 to 10 years is the usual age group that this presents in. And number five is conduct disorder. It's basically antisocial disorder, but in kids. So if someone's less than 18, but they're going like squashing bird nests, or causing harm to other people, other things, or violating rights of others, that's usually antisocial, but we just call it conduct disorder if they're less than 18. Okay, moving on. So, yep, Adderall. We're going into pharm for ADHD. Okay, so pause and then unpause when you're ready. All right, so lisdexamfetamine, it's a stimulant. However, it has a longer half-life. So what that means is that if you use a drug that has a longer half-life, it reduces the drug seeking behavior. Like they're not looking for more drug every 2 hours, because the drug effect stays for longer. So it's actually a good drug if you want to give it to someone who has a history of drug abuse. Okay, so longer half-life is preferred if someone has a big history of drug abuse. And it's option B, and it's not CYP mediated, so it doesn't use the CYP enzymes. Okay, number two, it's our atomoxetine. So I just want to point out number 2, 3, and 4 are the non-stimulant category. Okay, usually amphetamines and lisdexamfetamine, this is our stimulant category, but option 2, 3, and 4 are the non-stimulant category. So let's look at each one of them. So atomoxetine is a drug that we use in alcoholics or in cases of comorbid tics and anxiety. So we can use it in someone who has ADHD, but it's also alcoholic maybe. It's basically safe to use if someone is drinking alcohol. And also if a child, let's say, has like Tourette's syndrome or maybe anxiety and ADHD, this would be a good drug. However, this has a black box warning. It has a risk of suicidal ideation. Number 3 is our bupropion, and you will see this coming back again and again. I call this the magic drug. And there's a bunch of things we can use it for. So we can use it for ADHD, but we cannot use it in alcoholics with ADHD. So just make sure you remember that. Bupropion is a good drug for ADHD, but not used in alcoholics. What else can it be used for? It can be used for depression. It's a really good atypical, drug for depression, and also used for smoking cessation. Okay, so bupropion, ADHD, depression, and smoking cessation. Okay, and we'll come back to this drug. Guanfacine is a drug that decreases the sympathetic outflow, and it's not really used by itself, just used as an adjunct with with the stimulants. Okay, so here you can kind of see, hopefully this picture helps you understand the mechanism of action of these drugs. I just put this picture in for you. Okay, so we're moving on to personality disorders. So pause and then unpause when you're ready. Okay, so a 26-year-old PhD student comes to your office for a checkup. When you enter the room, she's upset, states that the nursing staff has been incompetent, and you're the only doctor who's ever understood her, despite only having one brief clinical encounter. When you tell her that you cannot prescribe her sleep medications, she states that you are incompetent and abruptly leaves the appointment. So you see how she kind of switches. She has these like two extremes almost. That's called splitting. Like at one hand, she's like, "Oh, you're the best doctor. You understand me," and at the other hand, she says you're completely incompetent. So this splitting, it's pretty classical of borderline personality disorder. They're very unstable. They have unstable interpersonal relationships with impulsive behavior and a sense of emptiness due to fear of abandonment. Number 2 is a 36-year-old female administrative assistant, does not like to socialize, does not like to attend social events. She's afraid that people will not like her. So she's not afraid of like being out in open, or in public. She's just afraid that people might judge her, because it's important to know the difference, because these are two different conditions, right? Her problem is that she's afraid that people will judge her. She would like to meet people but feels shy to initiate a conversation. So this is an avoidant personality disorder. The patient tends to be hypersensitive to rejection and socially inhibited, resulting from feelings of inadequacy. Okay, and they do want to meet new people. So it's unlike schizoid, where the schizoid patients don't even want to be with people. This is they want to be with people, but they're too scared to be with people. Number 3, a 35-year-old female says that the neighbors are planning to steal her things. She's attempting to pursue legal action and get her neighbors evicted, because she knows that they intend to harm her in some way. You can see that she's very paranoid. Okay, so when you have excessive distrust and suspicion of the other, it's a paranoid personality disorder. And number 4, you can see this male, he lives alone, rarely interacts with the family, and just comes to town once a month. And it's not like he wants to be around people. He's happy where he is. And this is schizoid. These patients tend to be, you tend to ignore them. They tend to get really ignored, and because they're just so in their own world, they're so like quiet. They just like sit in the corner, like loners almost. They're called loners in lack of better terms. So they have this emotional aloofness, indifferent to praise or criticism, and without any bizarre or idiosyncratic thinking. Okay, so voluntary social withdrawal and limited emotional expression. So here's a little summary. You have cluster A, paranoid, schizoid, schizotypal, which are weird. Cluster B is mostly like wild, with your histrionic, narcissistic, antisocial, and borderline. And then cluster C is worried, the avoidant, the dependent, the obsessive compulsive personality disorder. So make sure you have at least a decent understanding of all of these. Okay, moving on to somatic symptom and dissociative disorders. So pause and then unpause when you're ready to hear the answers. Okay, so a woman comes to the physician's office with paralysis of the left arm and paresthesia of the left leg. She reports that her left arm does not feel like a part of her. On physical examination, her mood is incongruent with the presence of her symptoms. She is unable to raise the left arm. However, she was able to obtain an object from her purse. So when you see so nothing's actually wrong with her arm, right? It's not a musculoskeletal issue, but she can't move it, right? She's actually affected by it. That's a conversion disorder. So it's not only that she thinks she has a problem, but she actually is showing some, I guess, neuro symptoms. This is conversion disorder, which was initially called hysteria. So they actually show altered sensory function or altered voluntary motor function. Clinical findings are not consistent with recognized neurological or medical conditions, and the patient's symptoms are not better explained by any other medical condition. The patient's symptoms cause significant distress or impairment in functioning or need of medical evaluation. Okay, number 2, patients are very worried about having or developing a serious illness. So they don't have any symptoms. They're just worried that they might get the disease. So that's illness anxiety. Okay, so they keep checking they keep checking their weight, they keep checking their blood pressure, their pulse. They're just really anxious. So illness anxiety disorder. Number 3, a 22-year-old woman is brought to the ED after fainting and subsequently having a seizure in the parking lot of a hospital. The patient was identified to be a nursing student, and a syringe was found on her person. Point of care testing for glucose shows hypoglycemia, and lab testing shows an insulin to C-peptide ratio that is more than 1. If you have very low C-peptide, you know that she self-injected, that she did that on purpose. And this is factitious disorder. This is where the patient falsifies physical or psychological symptoms or induces. So the induces is the word. She did this to herself, injury or disease to themselves, for some purpose. Maybe, we don't know what her motive is, but she is faking the disease because she did it to herself. Okay. For a 27-year-old woman presents to the PCP due to headache, chest pain, and food intolerance. These symptoms have been very distressing for her and reports that these symptoms have been present for approximately 8 months. So she does feel symptoms. Okay. She previously has seen a headache specialist, a gastroenterologist, and obtained a number of ECGs in the emergency department. Their respective thorough workup was negative. On physical exam, the patient appears healthy and is otherwise unremarkable. So she does feel the symptoms, but nothing is wrong with her. So this is somatic symptom disorder, where she feels the symptoms. It's been going on for at least 6 months. She's stressed by it, but physically she's absolutely fine. Okay, compared to conversion disorder, she feels the symptoms, and the symptoms show up when you do a physical exam. You're going to see that she's not moving her left arm, right? So that's the difference between somatic symptom and conversion. And then illness anxiety is there are no symptoms, you're worried about having the disease. So there are no symptoms, you're just worried. In somatic symptoms, you are worried and you feel the symptoms, but nothing's actually wrong. And in conversion, you're worried, you have the symptoms, and you also show the symptoms. Okay, moving on to anxiety. So pause and then unpause when you guys are ready. So social anxiety disorder, this is where the patient is scared to go out to social events because he feels that no one will talk to him and people will make fun of him. So social anxiety disorder is E. They're scared of going to social events. Very similar to what we talked about a couple slides ago with the avoidant personality disorder. Okay. But in this case, they are, they just tend to have, they desire relationships, they tend to be hypersensitive. However, in social anxiety, they get a lot of anxiety from going to social events because they feel like people will judge them and no one will talk to them. Then you have panic disorder. Panic disorder is the abrupt surge. It can happen anytime. There's really no trigger for this in most cases. Abrupt surge of intense fear along with shortness of breath, palpitations, a lot of physiological signs. You start to sweat, you get chest pain, shortness of breath. It's almost like having a heart attack, or can feel very much like an actual pathological disease when it's more of anxiety related. So these tend to be very recurrent, and the patient tends to always be worried and scared of when they're going to experience a panic attack, because there's no fixed trigger. So the patient is just constantly in anxiety of like, when am I going to get the next one? The Okay, we'll discuss the treatment on the next slide. Let's go to option 3, agoraphobia. Agoraphobia is C, patient is convinced that if she steps out of her house, she will die, get into a motor vehicle accident and die. Agoraphobia is where people are just scared of the outside world. They're scared of traveling on a bus. They're scared of standing in a garden, in an open, on the street. They're just scared of the outside world. OCD is obviously you have an obsession, which forces you, and because of which you have a compulsion to act on the obsession, right? So here, patient has persistent thoughts about bad things happening to her, so that's the obsession, and her compulsion is to pull her hair out from the stress. So this is your trichotillomania, and you can see how that can be a compulsion to an obsession. And treatment is our SSRIs. Next is PTSD. PTSD has to be for longer than 1 month, and usually exposure to some kind of a serious stress or trauma. If it's 3 days to 1 month, we call it an acute stress disorder, but it has to be longer than 1 month to classify as PTSD. And people will get flashbacks of the trauma, and most of the times these people don't know that they have PTSD. Okay, so we kind of have to, as physicians, identify and rule it out when they present to us. Then number 6 is adjustment disorder. Adjustment disorder is there's a stressor in your life, and the stressor can be it's a major stressor, but it's like a non-life-threatening stressor. Something like you lost someone very close to you, or you just moved to a new city, or you just lost your job. So some kind of non-life-threatening stressor. Because if it's a life-threatening stressor, you're going to see PTSD. If it's non-life-threatening, it's going to be more of an adjustment disorder. And this has to be situational. There has to be some stressor, and within the past 3 months. So the stressor has to be within the last 3 months, and the the course of adjustment disorder should be a maximum within 6 months of this, like maximum of 6 months. And there's really no treatment for this, because this is just, if you just lost a loved one, you're not going to give someone SSRIs. They're going to be a little depressed. They're going to have some negative mood, some depressed mood, but usually we don't treat adjustment disorder, but we will definitely treat PTSD. Okay, so what are some good drugs for generalized anxiety, social anxiety, etc.? So for anxiety, acute, if it's a panic attack, benzos are the choice of drugs. But remember, benzos are addictive. You can get dependent to them. So we only use benzos for acute purposes. We don't really use them chronically. For chronic use, we're going to start them on SSRIs like fluoxetine, paroxetine, sertraline, etc. And there's another very good drug for generalized anxiety, is called buspirone. And this is a drug that it's an anxiolytic, so it helps to calm you down. However, it's unlike benzos in the sense that it's not a hypnotic. It's just an anxiolytic. Okay, benzos tend to be both anxiolytic and hypnotic. Buspirone is only anxiolytic. And you have to wait at the bus stop, right? So for this drug to kick in, you have to wait for at least 2 weeks. It's not a drug you can use acutely, right? If someone's having a panic attack, you can't give them this drug and be like, oh, 2 weeks from now you're gonna be fine, right? So acute is benzos, and chronic is our SSRIs and buspirone. Okay, and bipolar and related disorders. So take a minute and then unpause when you're ready. So bipolar disorder sorry, let's start with number one. Patient is acting strange, sleeps only 1 to 2 hours at night, thinking, trying to save the world, talks really fast, has a history of depression, and symptoms last more than 7 days. That person is in a classic mania phase. This person is having a full-blown manic episode, and you have this mnemonic called dig fast that you can use to identify a full-blown manic episode. So bipolar 1 is where you see full mania. Okay, so this option is bipolar 1. It's option C. Number 2, patient is getting more distracted with pressured speech, does not cause impairment in function or require hospitalization. So you can see here that there is a manic episode, but manic-like, but this is not a full-blown manic episode. This is a hypomanic episode because there is no impairment in function and does not require hospitalization. So this is called hypomania, when you don't need hospitalization or no impairment in function. So this is a hypomanic episode, and hypomanic episode is seen in bipolar 2. So this is going to be option A. Option 3, patient has periods of hypomania and depressive symptoms, but has gone on for 2 years. Okay, when it's really long and not full on mania, just simply hypomania and depressive symptoms for 2 years, this is called cyclothymia. You're constantly cycling between a hypomanic and a depressive episode for a long period of time. Okay, so this is one Sally's flowchart for these, and hopefully this helps you. Okay, moving on, drugs for bipolar disorder. So take a minute and unpause when you're ready. Okay, so used for depressive episodes of bipolar disorder. So bipolar is going to have both manic and depressive, right? But for the depressive episodes, we do not use SSRIs, okay? Instead, we use quetiapine. So we're going to use quetiapine, which is an antipsychotic. And lithium drug interaction. Lithium drug interacts with thiazide diuretics and will decrease lithium excretion. Number 3, lithium adverse effects. Well, it can cause hypothyroid. It can also cause hypercalcemia. Okay, and then adverse effects are low therapeutic index, needs to be monitored. Blood level needs to be monitored. Acutely, it can give you nausea, vomiting. Tremors is pretty big. We can actually get lithium-induced tremors. Polyuria, thirst, nephrogenic diabetes insipidus. So lithium-induced nephrogenic diabetes insipidus. And chronically, like we said, we mentioned the hypothyroid, the hypercalcemia, hyper-PTH, and some cardiac dysarrhythmias. Okay, so lithium is our drug of choice for bipolar. It's a mood stabilizer, and that's what we go for. We don't really use SSRIs. When a patient comes in complaining of depression, it is your responsibility as a physician to ask about any previous manic episodes. Because if this person has only ever had depression and you give them SSRIs, they're going to be fine. But if this person, let's say, had a manic episode in the past that you are unaware of and you prescribe them SSRIs, you can precipitate a manic episode. So SSRIs are not our choice of drugs for bipolar. Remember that. Okay, so almost done. I think we're moving on to our SSRIs, depressive disorders. So take a second, and then once you're ready, you can unpause to hear the answers. Major depressive disorder, this has to be at least 2 weeks with, you can do your whole SIGI caps here. There's going to be loss of interest, anhedonia, and guilt. So SIGI caps is go-to here. Okay, number 2 is dysthymia. Dysthymia is C. This is for at least 2 years. It's a persistent depressive disorder, and it's slightly milder in the sense that you might not see loss of interest and guilt. Disruptive mood dysregulation disorder. So they have a disruptive mood, right? And they're not able to regulate their emotions. So they have these temper outbursts. So more than 3 temper outbursts for at least 1 year in ages 6 to 18 in 2 or more settings. Premenstrual dysmorphic disorder. This is 5 or more symptoms starting a week before menses and resolving within a few days of menses. So again, the symptoms are going to be very much like the different symptoms of depression that we usually talk about. Okay, so moving on to antidepressants. So pause and then unpause when you're ready. Okay, so fluoxetine, it's really one of the best SSRIs. It's recommended for children and adolescents. It's first line for bulimia. We can use it for GAD, generalized anxiety disorder, and social anxiety. So lot of uses. Second, we have cyproheptadine. Cyproheptadine is a serotonin antagonist. This is an antidote for SSRI overdose. Okay, SSRI overdose can cause hyperreflexia, clonus, and tremors. So you need cyproheptadine, can be your friend. Okay, duloxetine. Duloxetine is an SNRI with adverse effect of liver toxicity. Liver toxicity is big with duloxetine. Trazodone, more like trazodone, and this tells you what the adverse effects are going to be. Priapism, with very long erections and painful erections, and sedation. So this is a really good drug if you want for sleep. This is actually a very good drug for sleep. A lot of the people in inpatient psych units are on trazodone to help them sleep, and usually used as an adjunct to other drugs. Bupropion is, again, remember, our magic drug. And we say it's magic drug, so, remember we did it for ADHD, but we also said it helps with depression and smoking cessation. With depression, it's magical because there are usually no sexual side effects. So most drugs for depression will come with sexual side effects, but bupropion doesn't. So no sexual side effects. This is not used for anxiety, though. Okay, remember the drug for anxiety was your buspirone. Okay, number 6 is mirtazapine. Mirtazapine is your B. There's no sexual side effects. So again, that's, I guess, the second drug that will not show any sexual side effects, but it does have some adverse effects like sedation and weight gain. So maybe someone who is anorexic, this might be a good drug because it might help them gain some weight back, right? So you kind of have to use your adverse effects and like make them work for you. Okay, so again, just a picture for some mechanism of action if you're interested. Okay, and we're gonna end with psychosis. So just 2 questions here, and then unpause when you're ready. So 21-year-old senior college student referred to his academic advisor clinic due to increasingly bizarre behavior. Roommate reported that he often does not leave his room for weeks at a time because he's obsessed with the voices in his head. He believes he's the only one on the planet with a special ability, and you can see he's paranoid. You can see he's receiving some secret messages, and he's admitted to the psychiatric ward and started on low-dose risperidone. So this is your classic schizophrenia. This is a good age because usually schizophrenia starts around the age of 20. So for schizophrenia, you can see symptoms. You can have positive and negative symptoms. Positive are going to be more auditory, audiovisual hallucinations, delusions, fixed false beliefs, disorganized speech, whereas the negative symptoms will be more of a flat affect, social withdrawal, lack of motivation, catatonic behavior, etc. On physical exam, you're going to have to see the presence of 2 or more of these for at least 6 months. Number 2, a 35-year-old man believes his wife is cheating on him with a priest who has sworn celibacy for the past 30 years. Okay, he does not experience hallucinations or abnormal motor behavior. This has been going on for at least 1 month. So there's no negative symptoms. You can see there's no abnormal motor behavior. There's no hallucinations either. It's just a delusion. So this is a delusional disorder. It can be of different types. For example, a woman is convinced that her professor is in love with her. That's a specific type of delusion disorder. So everything is usually fine. It's just they have one crazy delusion that they're stuck up on. Okay. Here's a little like summary sheet. Make sure you know the difference between brief psychotic, schizophreniform, and schizoaffective. So brief psychotic is if it's basically schizophrenia lasting less than 1 month. Schizophreniform is lasting between 1 to 6 months. Greater than 6 months, it's schizophrenia. And if schizophrenia presents with a mood disorder, then it's called schizoaffective disorder. Okay, so let's say schizophrenia with manic episodes or schizophrenia with depressed episodes. Okay, and then you can go through your delusional, schizotypal, schizoid, paranoid disorders. Okay, and antipsychotics. You can pause and unpause when you're ready. So, patient has stiff, jerky movements of face, body, eye blinking, stick out tongue, adverse effects. So, what are these symptoms? This is tardive dyskinesia. Tardive dyskinesia is a long-term adverse effect of our antipsychotics. So, tardive dyskinesia, you can see the sticking out the tongue, the eye blinking. Okay, usually seen with our first generation antipsychotics, which are antagonists of dopamine receptors. Another more acute adverse effect of antipsychotics is extrapyramidal symptoms, or EPS. And so anytime we prescribe someone haloperidol or any kind of antipsychotic, we give it with benztropine, which is an anticholinergic, to avoid those extrapyramidal symptoms, which are more acute adverse effects. Okay, so that's that. Number 2, patient has weight gain, sedation, orthostatic hypotension adverse effects. So what drug is that? That's your olanzapine. So olanzapine is a type of atypical antipsychotic, and it's an antagonist at 5-HT2A receptors and causes metabolic syndrome as the adverse effect. Okay, number 3, partial agonists at D2 receptors. So a partial agonist, that's a really interesting drug, right? A partial agonist, that's aripiprazole. It's a great drug. We use this for bipolar, we use this for psychosis, lots of different things that this is used for. And what this does is it antagonizes the effect of full agonists. So in places where we have a lot of dopamine, it will lower or antagonize the receptors. But also in places where we don't have enough dopamine, it will act as a partial agonist and will increase dopamine. So where we have a lot of dopamine, it will antagonize. Where we don't have dopamine, it will act as a partial agonist and will increase. So we can also use this for Parkinson's. So really great drug. You should remember this one. Number 4, patient needs weekly blood tests to monitor for agranulocytosis. This is another atypical drug called clozapine, and we do have to monitor weekly. Okay. And that is all. I will see you guys all in the next video, which is our neurological disorders with treatment. Thank you guys.